Hi, this is Jessica DeMassa, and I'm here at the HISA Studio at HIC 2017. I'm here with Susan. Susan, please introduce yourself.
Hi, I'm Susan Smith. I'm a clinical research coordinator at the Department of Cardiothoracic Surgery at the Prince Charles Hospital in Brisbane.
So tell me a little bit about some of the projects that you're working on, because I understand that you're trying to integrate some of the historical clinical data that you've found with some new data. Tell me what you're working on.
So we carry out clinical research in cardiothoracic surgery, and a lot of our work is trying to establish what procedures are the most useful in their outcomes for our particular patients. So that requires retrospective analysis of data that we have already collected in our outcomes registry. So we've established quite a long history of data from our patients which look at the patient's outcome, and then we link that information also to the Queensland Birth, Deaths and Marriages to look at their long-term outcomes. So a study that we've just completed is looking at the outcomes for patients having redo aortic valve replacements. They're a fairly small group of patients, and the risk is usually much higher in that particular group of patients compared to first-time AVR. But because we're the largest centre in Australia and probably comparable to many of the largest centres in the US, we actually have a relatively large cohort of patients, which gives us the ability to look at the outcomes of these patients. So we were able to link the death information from the birth, deaths and marriages, and then compare that to what the life expectancy is for a matched group of normal people in the Australian population. And we found that we actually have very good outcomes for this high risk of patients, so that for up to 6 years post-operatively their outcomes are actually they're not statistically different to the normal population, but it does decrease a little bit thereafter. But we were also able to identify what characteristics then contribute to poorer survival. We found actually that it wasn't so much issues to do with surgery, but in fact it was diabetes, that it's a lifestyle factor that is still more important in the long-term outcomes for this group of patients.
Okay, Susan, so that's a very practical example of how you've managed to set up that research and augment it and actually find something that you weren't really looking for in that data. What advice would you give to others that are undergoing a similar process in terms of trying to use their clinical data and augment it with other data that's available, in terms of how do you go about that? What advice would you give?
I think something that we're lacking at the level of our health services are epidemiological skills. So we have a lot of desire to use our data retrospectively, and a lot of business intelligence and so on is coming from the financial and executive management side, which is great. We really need this and it's really useful and helpful, but we want to move towards a level of clinical intelligence where we're actually able to do the sorts of studies that relate more specifically to clinical outcomes rather than just financial outcomes, for instance. And we need to be bringing the competencies, in particular in relation to epidemiological and very high-level analytical skills, into our clinical area, but also integrating that with the knowledge of informatics so that we understand where to get the relevant data from and how to integrate it and then use it, with the caveats around the deficits of particular data groups that we might use.
So really, it almost sounds like it's a human issue that's kind of holding this back in terms of training and having the right people with the right knowledge. Is that right?
I think so. And to some extent it's perception as well, because this sort of work is commonly called research, and it is in fact research, but research is very much a spectrum between quality assurance and then full-blown research. But we need to be moving our quality assurance activities, which relate to evaluation of services and evaluation of what's the best procedure for our particular patients. We need to move that kind of quality assurance a little bit more towards the research area, so that we're applying the techniques that might be used more consistently in research to our quality assurance and evaluative exercises, so that we're getting really good understanding of what's actually going on. And in the same way, some of our research activity needs to move a little bit more towards this qualitative and evaluative sort of population health-based work.
Now, if we move to that middle area, I suppose, where the two sides meet, what's the benefit of that? What is to be gained?
We gain a better ability to scientifically evaluate the outcomes of our services, and that then informs our clinicians as to the best direction that they can go for their patients.
And so really it is about improving patient outcomes at the end of the day.
It is. It's about improving patient outcomes. It's about providing the evidence base so that clinicians can make their judgments for their clinical care based on the evidence within their own particular population in particular.
Thank you so much for sharing a little bit of the insight on your research and also your experience working with developing such a robust look at data and integration from a clinical standpoint. We enjoyed hearing your perspective. Thank you so much, Susan. Thank you. I'm Jessica DeMassa. I'm here at the HISA Studio at HIC 2017. Thank you.